Hi everyone. You are in ICU and you see a X-ray which has pneumothorax and the patient is intubated and mechanically ventilated. First thing you have to do, you have to go and increase the FiO2 to 100% and decrease the PEEP. Also decrease the pressure support or tidal volume. Next thing, you see the hemodynamics. If this pneumothorax had led to hemodynamic compromise, you have to immediately put a intercostal drainage. So in such case, earlier it was done in the second intercostal space. Now it is directly done on the fourth intercostal space, fourth to fifth intercostal space, and anterior to the mid-axillary line. And you for further confirmation, you can do a bedside POCUS. You can just put a linear probe and you can see that there will be there you can see that there will be absent lungs sliding there. And if the lung sliding is absent, if the B line is absent, the lung sliding is absent, and also you get if you get what we call is lungs point. Lungs point is where there will be one side there will be lung sliding, and later you see that there is a absence lung sliding. The place where there is this transit area means the area on one side there is a lung slide, means lung sliding is there, means there is no pneumothorax, and the area where there is a pneumothorax there will be no lung sliding. So this transit point is called lungs point. And M mode, when you will put, then you will see where there will be a lung sliding, there will be a seesaw sign, and where there will be a no lung sliding, means where there will be pneumothorax, you will see barcode sign. This lungs point is a very pathognomic, but generally it's difficult to find out, and if you get, that is 100% conformity. Other than that, in physical examination, we all know what you will see. You will see that there will be a trachea shift to opposite side. The apical sound will be shifted. Basically there is air inside the pleural space, so it will push it out. So if it is a pneumothorax in the right side, the everything, the medicinal and everything will push to the left side. If it is on the left side, it will push to the opposite right side. So if it is a tension pneumothorax, and you will also think there will be decreased lungs movement, chest movement, diminished air entry. There will be a resonance on percussion, absent breath sound. So these are all confirmatory of pneumothorax. Also there will be, if the patient is on mechanical ventilator, you will see that the graph, there will be a peak airway pressure will increase, and along with that plateau pressure will also increase. Okay, so there will be alarm. Suddenly if someone comes to you and they says that, ma'am, go and see, there is some alarm is ringing, I don't know what has happened suddenly. So if you go and see that there is a sudden increase in peak airway pressure and plateau pressure, and the patient is on mechanical ventilator, there is a chances that patient might be having pneumothorax. So these are the findings. In such cases, if there is a hemodynamic compromise because of pneumothorax, means there is a tension pneumothorax, immediately you have to put ICD. So this is for the patient who is on mechanical ventilator. If the patient is not on mechanical ventilator, in such case, and if the patient is the X-ray shows pneumothorax and the patient is not having hemodynamic compromise, then you can put on 100% oxygen with an RBM. You can put on 15 liter of oxygen through an RBM, non-breathable and rebreathable mask, and then you can see further you can see the ultrasound you can do. If in ultrasound you see this pneumothorax is, if it is greater than 2 centimeter, or it is covering more than half of the lungs filled, then in that case you may have to go for ICD insertion, or if it is less than 2 centimeter, and then in that case it can be managed conservatively with monitoring, and we need to find the cause, if it is whether it is iatrogenic, or whether it is a primary pneumothorax, or whether there is some other lungs condition which is because of secondary lungs condition. We need to find out, accordingly treat the cause. Thank you.